So I'm going to focus today on community testing. And I mean, it's impossible to explain everything about community testing in 2 hours, let alone in 10 minutes or 15. So we're going to go through general overviews and a few key topics. And I'm going to do this mostly with an example of a project that I've been coordinating along with some colleagues here in Portugal for the last few years, which is a testing project in community-based testing sites. So this is kind of a short list of some of the stuff that I've been doing. If you're interested, you can check it later. In terms of background, this is data that was published last week. It's the joint report from ECDC and WHO. They always do a surveillance report every year for HIV. And so this is the rate of new diagnoses per 100,000 people in the different countries of the WHO region. As you can see, the rate in the region is 15.6, but in the EU/EA it's 5.4, which clearly shows you that this is a much bigger problem in the eastern part of the region. Although we can't forget that in the western part of the region, there's also quite a bit to do as well. So the number of people who've been living with undiagnosed HIV is increasing in the region, but decreasing in the EU, like you probably understood from the slide ahead. You can see on the small dots that those are the targets for the region. So the dots down here, not the ones on top. And I mean, as you can see through the progress, this year we should be much lower, or we should be lower than we are. So we're pretty much a long ways away in general, for speaking of the entire region. In terms of late diagnosis, we haven't improved either. So 53% of people are still diagnosed late. That means with under 350 CD4 cells. And what that means is that, I mean, you have two things. First of them is it has individual level consequences. So if you're diagnosed late, as you know, there's a much bigger probability of HIV having an effect on your immune system. And secondly, there's an issue of public health, which is if you don't know that you are living with HIV, you have no idea that you need to be on treatment. And so you continue to behave normally, and it's possible that you transmit the infection towards others, whereas if you're in treatment, as you know, you can't transmit the infection. So going now to community-based testing specifically, this is from 2018. I haven't seen the data from this year yet. And it shows you in which countries is community testing by lay providers implemented. And you see that it doesn't look very bad, but it doesn't look very good either. This is an estimated coverage, so it's not a real coverage. It's an estimation, so it's higher than reality. Well, this specific estimation is higher than reality. And still you see a lot of red and a lot of light green, which means that there's still a big way to go to make this available as a testing option. If you look at community-based testing by trained medical staff, you see that the panorama is completely different. So half red, almost all green. Apologies. So the thing here is when we're speaking about community-based testing, community-based tends to mean that it is in the community. And when we speak about community-based testing, we generally mean that it's not only in the community, it's also involving the community in some capacity. But there are a lot of places where testing can be done in the community, but only health staff and sometimes only doctors can provide it. So you have two definitions or two concepts around community testing, which are the place. So community testing is generally seen as being testing close to where communities are. And you have obviously the, sorry, I'm blanked here for a second. Place side and provider side. Sorry about that. Which means that you can have people getting tested in a community setting, and it's only doctors that are providing the testing, or in same setting or similar setting, other country, you can have lay providers doing it. We go on to self-testing and self-sampling, and what you see here is self-testing in 2018, and what you see here is self-sampling, which is surprising, right? Thing is, self-testing, for example, has been having a lot of push in terms of advocacy. Self-sampling is there for several infections for a long time, and there's much more commercial interest around self-testing than self-sampling. So it has been scaling up quickly, although, as you can see, and again, it's still the coverage is still way below what is expected. Although this map has changed since 2018, but there's no more recent version available yet that I know of. Another issue is that when we're looking at understanding the epidemics is this. So again, this is data from 2018. I haven't had the time to look at the 2020, all of the 2021 yet. But what you see is that we don't really understand. So in most countries, there's no real understanding of the HIV and viral hepatitis and STI epidemics among key populations. What you see here is how many countries are capable of reporting reliable data regarding the continuum of care for key populations in the EU EEA. And this is the overall number. So it's extremely underwhelming, and it means that we're missing links to the most important people to controlling this epidemic. So we spoke last time about a testing system. And the testing system, for the most part, is service provision and then everything around it. Generally speaking, you have to test in multiple ways towards, you have to have multiple approaches because no one approach suits everyone. So there's a series of things that should be always done. Indicator condition testing, testing pregnant women, provider-initiated counseling and testing where you have concentrated epidemics, of course, community testing, self-sampling, partner, etc. All of these are very well described. Christos talked about this last time on the regional guidelines, so you can definitely check those because they provide you a very good overview of the different strategies and where and how are they recommended. So most of the testing is done here. And for the person, your contact is mostly with these three places that have the arrows. So we don't see, in general, the rest of the system. What we see are the contact points that we have. So community organizations, primary care, and clinics. But all of these settings are very different. And you have, as I mentioned last time, you have a lot of options in the different settings. And again, as you go up in terms of complexity, biosafety, and number of tests that you can do per hour, you kind of lose on proximity, on access, on low barriers to actually accessing the services. You have to have more training, you need better equipment, you need more biosafety, etc. So there are, again, advantages and disadvantages on the different levels. Again, usually testing systems are vertical, so communication is not often working, which means that for the person, if you have to run around getting tested and getting medical appointments, it's a mess. So going to community testing, why is integration important? I'm going to go through the practical, so the real world value of integration, but I just want to recap this. When we usually speak about integration, we speak about integrating new tests, but we have to look at integration from a much broader perspective and look at integration as in a synergistic way. I don't usually like to use very round words, but so what we have is that as systems are usually built vertically to respond to one infection, it's very rare that they're working in articulation with others. And so there are many countries that have specific waste disposal systems for HIV and then others for TB, or for sample transportation, the same thing for TB one and then for HIV another. And so there's a lot that can be gained from maximizing your opportunities. Also in terms of case finding, and I'll show you data about that in a minute. But the thing is that here we have to keep in mind that for the most part, HIV, viral hepatitis, and STIs are infections that affect specific populations more than others. And these populations that are most affected tend to be those with the biggest structural vulnerabilities. So usually people with either less information, less money, less access, or who are marginalized and discriminated. And this is valid not only for these infections, but for many others, but it's more than proven that in these infections, this is the scenario. The specific populations change for country to country, but it's always in this logic. And so we have to keep in mind that getting tested is not a priority for people. And so when we're providing a service, we have to provide a service that suits the needs of people. And testing is one part. It's important, and we know that it's important, but we have to be aware that for the person, that's not going to be their first, second, third, fifth, or 10th priority. So going practical, I'm going to speak to you. There was a small formatting error there. Sorry about that. I'm going to speak to you about a project that we've been implementing in Portugal since 2015. It's promoted by GAT in a partnership with the Institute of Public Health of Porto, formerly with immunohemotherapy lab, the complicated name, of a reference hospital here in Portugal, and with the support of AIDS Healthcare Foundation in Europe. What you see, the logos that you see below are a few of the organizations, are all the the organizations that started the project, so our founding fathers and mothers, so to say, and a few others that joined. The logos are not updated, but I couldn't find all of them, so it's around half of the logos here, I think. So each of these organizations, or several of these organizations, have multiple testing sites, and since 2016, we've all been collecting the same data in all of these organizations around the country. They all provide services to key populations. So what we're doing is we're providing integrated testing for HIV, Hep B, Hep C, and syphilis, and in some cases other STIs, but that data is not here because it's center by center, it's medical appointments, so it's slightly different. And we're focusing on populations who are already proven to be at higher risk of HIV and viral hepatitis and STI infections in Portugal. So people using drugs, sex workers, men who have sex with men, and migrants, mostly migrants from high endemicity countries, specifically Portuguese-speaking African countries and Brazil. What do you see on the maps? So on the left, on the red map, you see the points where we have a member organization or a member testing site. And on the right, you see the incidence of HIV in 2017 in Portugal, I believe. So as you can see, we're concentrated on the places with the highest incidence, which are also the places with the highest populations. This is also because many of these projects are supported by the National HIV Program, and so they're obviously funded to do intervention in the hotspots. This is kind of the overview of what we do. So we provide support. We provide usually, so far we've provided tests and consumables, provide data collection tools, training, external quality control, et cetera, and everyone has been kind of. So when we started this, there was only HIV testing in Portugal in community organizations, and now all community organizations are providing at least these 4. And what you see is the evolution of tests in the first couple of years. And you see that there's a small increases, as you can imagine. For those of you who know it, the peaks there are Novembers, so it's testing week. And what have we learned from these 4 years? First thing we learned is that, in fact, it's almost a crime not to have an integrated approach. If you're only offering HIV tests, you're doing something wrong. Why? So again, I think you were all there, but just to make sure, these are Venn diagrams, and so what they represent here is the intersection amongst these 4 things: Hep C, Hep B, HIV, and syphilis. And you read it like this in eggs. So this is all HIV. So as you can see, we had 361 reactive results for HIV over these 3 years. Well, actually, it's 2 years because it's 3 years, 2016, 2017, and 2018, exactly. It started, data collection for real started in January 2016. But beyond these 361 here, you also had another 26 that also had a hepatitis B infection, and another 4 that also had a syphilis infection, et cetera, et cetera. In practice, what this means is that if we're only offering HIV, we would have picked up all of this egg here, but we would have lost all of these people. And all of these people would have gone to a testing site, would have made a test, and would have been told, no, you're okay, you can go. when they have, most likely, because this is not a diagnosis, it's a indication for diagnosis, but most likely they have a treatable or curable infection that we can test for 2 or 3 years, and they weren't offered the test. So we've proven that it's wrong to just offer HIV. That doesn't mean that it's possible to offer all of the others everywhere. I know that, but it's wrong to just offer HIV. And this is valid in any context where you have more than one infection running around the community, which is pretty much everywhere. So as an example, and the volumes are small because, as you know, Portugal is a small country, but only community organizations, only these community organizations, it's not all the ones in the country, over these 3 years, we would have lost 2,019 people if we were only offering HIV test. And all these 2,019 people have most likely an infection that's treatable or curable. And they went to us, or we went to them, depending. Another thing that we learned is that, I say this like it's something very new, but sometimes we forget about it when you speak about things, is that key populations, I mean, people, I use always the same expression because I think it's the most straightforward one. People are not boxes. And when we speak about key populations, we tend to speak about key populations as if people are a category, which is not true. What this means is that, I mean, same logic in the Venn diagram on the right. So you see that over these 3 years, we had a lot of data here doesn't include checkpoint. That's why there aren't many MSM here. Usually this would be around, the overall here would be around 11,000, but this is exclusively data from the others. Regardless of that, what you see is that we have a huge amount of migrants, but many of these migrants are also either MSM, drug users, sex workers, same thing for people who use drugs. Besides using drugs, they're also MSM, migrants, sex workers, etc. And so when we speak about services for a specific key population, we have to be aware that the fact that I have a service for people who use drugs doesn't mean that the people who enter my door are all the same. And I've recently prepared a similar presentation where I use the same example that I'm going to give you, which is we have in GAT a harm reduction center, so focused on people using drugs, of course, and testing and sexual health service center for MSM, which is Checkpoint Lisbon. But in both places, you have people going in that are both MSM and use drugs, but they're completely different people, even though they are still MSM and people who use drugs. And in both places, there is the risk of bad attitudes and discrimination or prejudice from the people who are providing the service and from the people who are in the service, unless everyone is trained and aware that they have to behave properly and they have to create an enabling environment at all times. What I mean by this is we've had several cases in the beginning, especially in the harm reduction center, of homophobic remarks. And there are people in the center who are gay, both in the staff and in the users. And this created kind of a weird environment. And we did a series of, I wasn't directly involved because I never worked in Moradia, but my colleagues there, they did a series of events speaking about rights, human rights in general, then specific rights of people who use drugs, and then specific rights of LGBT people. And it worked very well. And it really changed the way that LGBT people are welcomed in the center. But it's something that you don't usually plan when you're thinking about a harm reduction center. So to give you also an idea, I mean, the epidemiological distribution is also completely different. And so in many settings, it's good to have data because we also know what we don't need to offer people. Obviously, we know what we need to offer. So in migrants, for example, as you can see, like the quantity of hepatitis B infections is enormous because we have a lot of migrants from high endemicity countries. And so we have to offer HBV to migrants. Syphilis, for example, is much higher than we expected initially. So we really have to offer syphilis to migrants. If we look at people who use drugs, for example, as you see, the numbers in hepatitis B are much lower. And when we look in detail, we understand some of the patterns, so we can focus that. We don't have to offer HBV to everyone if they're people using drugs born in Portugal, for example. whereas we have to offer hepatitis C, logically. Again, just to same slide again from last presentation, just to say that sometimes people underrate community services. And this was the first exercise that we did with a few of our colleagues from other checkpoints to show the power of sometimes one community center. And as you can see there, Barcelona and Seville in Spain, which is a country of 80 million inhabitants, 2 community centers diagnosed 9% of all MSM in Spain. In Greece, 2 centers diagnosed 37%. And in Portugal, we diagnosed 23%. So you can have a huge contribution towards not only controlling the epidemic, but also to helping people finding their status and getting access to treatment. That is, I mean, much higher than even I would expect in the beginning, but it is possible, and with a much lower volume of tests than you would do otherwise. And it has to do with the targeting and the quality of the intervention. I'd just like to acknowledge Anastasia Faris for passing me the slides from ECDC's report this year and the rest of the team. Obviously, questions, etc., feel free. And this is an introductory talk, so I didn't go very much into operational details, also because I'm not sure that you will all be providing testing or in charge of testing services. But I'm completely available to go into technical details if you want.
Yeah, could I jump in?
Yes,
so
please.
Hi, I'm English and I'm living in Iceland, and we have no coverage at all for community-based testing. So that's something that I personally want to change, but I know because the numbers are so tiny here, we have a population of 320,000 people. So we're kind of being told, what's the point? But for the last 3 years, HIV diagnoses have increased every year. So we're on about 30 people that are being tested each year. So it's definitely something I work with the National HIV Charity. It's something that we want to put together. What would you say was the first suggestion of putting a program together? Like, what resources or reasons would you say? I know the benefits that you've just said were brilliant. How could we compact that in an argument?
So I have multiple possibilities for you, but I don't know the context of Iceland, so it's difficult for me to say I think this is a good strategy. I think there are multiple strategies that you can use. I do have a suggestion though. We can discuss initially here, and I can give you a few examples because I think it's good for the discussion that we'll have forward today. But I'll be in charge of a few sessions with you guys further ahead on advocacy. And one of the things, well, you know now in advance, you would know in advance regardless. One of the things I will ask you is to pick a topic that you want to work on. And we'll go through the sessions around your own topics. So if that's something that you're interested in, I suggest that that's something that we can maybe work in detail over the next sessions. But to give you a few examples, Iceland, I don't know specifically. I know very broadly the context. I know that it's, again, a very remotely populated country with not a very high population. But I think that the challenge more than the population itself is the dispersion of the population, which makes it hard to implement fixed testing responses, for example. So it would have to be something either mobile or remote in some way. I think that you have multiple possibilities without even having to have lay workers doing testing in a first stage. So you could have a community-based organization, for example, leading a self-sampling or self-testing program. And that can be done in a partnership with national laboratories to ensure quality. So it relaxes people on their side. And it gives you guys the initiative to kind of select the dissemination targets and how you want to do the strategy. So I think that could be a good starting point, because usually changing testing from doctors only or health staff only towards non-lay workers takes a while because it has legal repercussions. So even if people agree, they have to change the law, and changing the law usually takes some time. So I think there are quicker steps that you can give to start while not losing that from sight. Because again, in a country so I mean, Iceland is big in territory, and so I think that a fixed center is very hard to get people to mobilize to go. But currently there are a lot of options, and even a mobile laboratory is a possibility for multiple infections. And you can do something it's again, there are advantages in a small country. You can do something that's like supported by the national program. I think Iceland has something beautiful that it can focus on, and not many countries have, which is we're getting to zero. We're going to diagnose everyone, get everyone on treatment, and we will have zero infections. And I mean, you have the structure for it, you have the financial stability for it, and if you have the will for it, I think, I mean, it's easy to sell it like this to the government, and you can tell them the same, not for one infection but for several of them. So I think it's an easy sell. You just have to wrap up the plan. I can give you a hand with that.
Thank you. Brilliant.
Okay, if no one else has any question, we can start with a second presentation from Maka.
Hello to all. So my presentation is about country Georgian situation, about community-based testing as well. I want to share you some our story about peer-driven intervention and optimized case finding of HIV cases. I will try to be brief, but in case you will need additional supporting information, please stop me and give me the questions. So the background, we have Georgia remains low HIV prevalence country, and we have concentrated epidemics among drug users and MSM population. Female partners of these groups are the bridge to the general population for HIV transmission, and currently in early 80s we had such pictures that more than 80% of total registered HIV cases were attributed to injecting drug use, but now currently the proportion of injecting drug use transmission is decreased too much, and it's only 36%, and the dominant became the heterosexual contact and MSM transmission. So if you look at the slide, you will find HIV prevalence higher in European region. It's 21% among MSM population. And HIV prevalence among drug users is equal to 2% due to very big amount of efforts in harm reduction programs. So the main source for funding of HIV testing is state program and the Global Fund program. But the program for high-risk groups are mainly funded by Global Fund. And just 6 months ago, government initiated firstly to fund testing, this anonymous testing for key population. So we have testing for drug users, MSM population, female sex workers, trans people, and all those sex partners. This is a program I'm the director for already 10 years. We have 16 harm reduction stationary and 9 mobile ambulatories, and more than 200 outreach workers throughout the country. And depending on the HIV prevalence and also prevalence of drug users per region, we have mobile ambulances and stationary sites inside. This is number of services we are providing, but here I would just briefly to outline that 79% of our program outreach social workers are community members, and this is the key factor for our successful implementation of the community-based testing. I want to outline that 65% of our total testing at community-based organizations are executed at outreach settings. So why community members? Why do we select and hire these community members to implement HIV testing? They are trusted by other community. They have good connection networking and mobilization skills. And they know exactly who are their clients, what their clients need, how to deliver the services, and when to reach them, what time during the daytime, for example. This is a picture of our ordinary harm reduction site. This is quite not luxury one, quite simple, and gives, but it includes comprehensive services needed to people who inject drugs. This site in Tbilisi, also not luxury one, quite simple, and provides includes the services needed to local people. From 2017, our program joined the European HIV Testing Week, and twice in a year we are conducting broader campaigns, not only for drug users or MSM population, just to general population as well. Why to general population? Why we choose this approach? Because we want to reduce the stigma and self-stigma toward drug users. They don't want to be considered as drug users by other peoples, and they also want to avoid police, and other way we also reach unreached people in these mobile units during pre-counseling or post-counseling. We discover risky behaviors of those people, and may we reach new clients and then involve them in our harm reduction sites, and we refer them to our stationary sites depending on the location and addresses the client prefers. This was a success story of community-based testing in Georgia, and here is below the link of this article. You can find and read what was our achievement in 2017. I want to highlight importance of point-of-care diagnostics on hepatitis C among drug users. Georgia belongs to a country with higher Hep C prevalence in European region, and even in general population, it's 7.7%, and among drug users, it was acknowledged more than 80%. So we found hepatitis C program as a quite attractive service to invite people for HIV testing as well, because as I mentioned, Georgia is not high HIV prevalence country, and people consider, especially drug users, consider that HIV is not their disease and they should not get it. But what in case of hepatitis C and hepatitis B, they are quite interested in coming for services, and we are offering other screening components like testing on syphilis, screening on TB. So the screening on 5 diseases are available at one point. At this picture, you can see the machines of Cepheid. This is a very, very good possibility to receive confirmatory HCV diagnostic at harm reduction site. The machine is quite portable one, as you see on the table. The person who will be Hep C screened positive can be referred directly to the confirmation. In a couple of hours, in 90 minutes, he will know about the results. In case his viral load will be detected in the blood, he will refer to doctor in the same harm reduction site, and he can take the pills in the same day. So we call this approach one slot shot service, one window service. So all the above mentioned services are provided at the very ordinary harm reduction site within Hep C elimination program of Georgia. What the challenges do we have in Georgia? This is criminalization of drug consumption and marginalization of risk group. We have quite strict drug policy, and this is the main factor for increasing transmittable diseases among injecting drug users. So stigma and discrimination, including by medical personnel, is a quite concerning one in Georgia. Lack of innovative and supportive programs to reach hidden population, to find new clients is also problematic currently. Reduction of funding of community-based organizations and testing in ICA region. This is a common problem currently, as the Global Fund decided to leave our region and is restricted its funding. So another problem is that we have increased number of testing indicators by donor year by year, and it's difficult to manage, especially during these COVID circumstances. And another problem that we have at community-based organizations, this is a rapid changes of community staff in the organization. You know, these people are quite, they are moving from city to city, moving to other countries. Not now, not now they are locked inside, but as usual, they are going for as labor migrants or are imprisoned or have severe medical conditions. So we have to find new and new community members, then educate them how to provide the counseling and testing correctly, and then deliver all the tasks that are doing the previous one. So this also takes time, takes resources, human resources, financial resources, and so on. But as I see, it's not only Georgian problem. This is a usual problem for many countries. Now about this innovative method for increasing HIV testing coverage that we are using in Georgia. This is peer-driven intervention, so-called PDI, and optimized case finding, we call it OCF. So the PDI was not invented in Georgia. It was invented by Robert Hackathorn in USA, and this model was then developed in USA to reach drug user population from different networks. After then, Ukraine started the model developing in the country, and from Ukraine, Georgia invented and adopted this program, and it's already 10 years we are using them, and it's proven, the model is proven to be most effective in reaching to a large number of people in a very short time. It supports the programs to increase their HIV testing coverage. You rely on internal power of drug user social networks while maintaining total control over intervention and outcome. So this model gives you possibility to drive the recruitment by providing bonuses for particular population, for example, younger drug users, female drug users, and so on. Each of them are given 3 coupons, and for each coupon they are given the financial incentives, bonuses. So each drug user can bring with himself or herself only 3 persons, and monetary incentives are given for education, recruitment, and the testing. So this is the picture that outlines the traditional outreach model. When we have traditional outreach, so we have community members that can reach only drug users from his own networks or friends of friends. This is the number is defined, and in this green cycle, so you can see only his friends of this total peer outreach worker. And the green spots here, not green but blue spots, are left outside our coverage. So the PDI model gives possibility to reach more deeper and find those drug users, those risky population that were not covered before by any prevention programs. So the first one we call the seed, and the seed is given 3 coupons, and each coupon is given 3 coupons. I have very few slides from my presentation. Just as an example from Georgia, during 10 years, we have reached about 2,000 new drug users in this program, and 20% among them were women, and 15% were young drug users. Besides, we use the peer-driven intervention as a model to gather information through questionnaires. Like this is a big questionnaire, like we are using in IBBS studies. So the results of the research we are using for HIV service design year by year. This is recruitment chains from one of Georgian projects, and you can see here the recruitment of 4 seats. You see the 2 big recruitment waves and 2 small. This is another city recruitment chains. You see that this site did its best to recruit new drug users for the program. And this is recruitment chain from small city in Georgia, and the number are limited later, but for small cities it's enough, and we have benefited from this. And optimized case finding. This is very similar to peer-driven intervention, but the recruitment here starts from HIV positive case. So each case is given 3 coupons to bring with them their sexual or needle partner for HIV testing. And look at the picture. Sorry. And this red ones are HIV positive cases, and the other green ones are recruited HIV negative cases. So these chains are starting from each new HIV case that is discovered at our harm reduction site. So this is quite interesting model to find new HIV cases. Thank you. This is my publication. You can find them, any findings. In case of questions, I am ready.
Thank you, Maka. Maybe if you want, maybe we can go directly to Christos' presentation, and then we can have a discussion after. So you can take a break with your voice, Maka. Would that work for everyone? Yeah, great.
Okay, fantastic. So thank you, Maka. Well done with coughing. So you did a great job. So I'm going to try to give you our approach in Cyprus, which is going to be a slightly different presentation because of the nature of the island. So first of all, let me say that I've been a volunteer for the AIDS Solidarity movement for the past 5 years. And since October 2020, I'm the executive director, and I continue to be the executive coordinator, not director. And I continue to be a community health worker in the checkpoint and the sexual health trainer. Now, I'm going to start immediately with some numbers here just to get an idea of low prevalence data. This data I've extracted from the report of ECDC and WHO that was published on the 26th of November 2020. As this year, because of COVID, apparently our ministry didn't have any press conference or any press release. So I had to extract the data from that report. And just to have an idea, this is the last 10 years. The first HIV infection in Cyprus happened in 1986. And in 1989, the AIDS Solidarity movement was established 3 years later. So you'll see that up to now, we have 1,326 cases registered in the system, but they are not all new, because around 20% is, especially for the last 10 years, is a percentage of people who already knew their status and returned to Cyprus, either being Cypriots and living abroad, or European citizens of the EU who moved to Cyprus and registered in the national system. So you can see that, for example, for last year, we had 100 new registrations in the system, let's say. And if we see the last 10 years, what is interesting to see is that the MSM population, men who have sex with men, had a rise in 2013-14. We went from having around 20 to 30 diagnoses every year to 39, 50, and then the last 2 years we have a small drop. Of course, the numbers are so small that we can't really speak about an increase or a decrease. But why I'm mentioning this? Because in 2014, the Ministry of Health in the Republic of Cyprus asked the ECDC to support it in order to understand whether this rise was real, if it was because of people being more, because of more tests, or because it was a real approach, a real increase. And the ECDC came and did an analysis and a report in 2014 that actually suggested that the ministry would adopt and implement community testing. So that was a great timing for us. I'll give you some data and then move directly into the actual points. I'm not going to stay too much on the data. These are the data of 2019, of last year. So you can see that we have most of the cases between 30 and 40 years old, 39. And these are the breakdowns between Cypriot citizens, including Greek Cypriots and Turkish Cypriots, who are being monitored in the south, in the so-called Greek side, let's say. I'll talk to you about it in a while. And the second line is people who are not Cypriots. So why this is important? Because that actual year, the 2014, allowed us to cooperate as a community organization, to cooperate with Positive Voice Greece and ask them to come to Cyprus and start providing community testing on the island. Now, we had nobody who was trained to provide community testing, and the Greeks were the only ones who were actually speaking Greek and could help, at least in our side, in the south. So in 2015, we had only 6 locations that community health workers from Greece did the tests. And then in 2016, we did trainings and we started doing testing ourselves. So you can see the locations here. The data for 2020 is before the European Testing Week. And you'll see that the HIV rapid testing that we did was in total around 3,000 tests, where we had 19 reactive new cases. And half of the tests that we did were multiplex, so they were syphilis and HIV, and we had 49 in syphilis. So with half of the test, we had more than double. Now, a few things about the reality in Cyprus. For the people who don't know what Cyprus is or where Cyprus is, it's a small rock, a small island under Turkey, between Turkey, Lebanon, Cairo, Egypt, and Greece in the Eastern Mediterranean Sea. Now, what is interesting with Cyprus is that it's not just a small island, but it's also divided into two parts. So the areas that are controlled by the Republic are in the south, and the areas that are controlled by the Turkish army are in the north. But people can actually cross to one another. And as an LGBT community and people who are in the community, of course, nobody discriminates in who you have sex with. So people from the north have sex with people from the south and vice versa. People move around the island. They cross through checkpoints. When I say checkpoints, I mean actual roadblocks that you have to cross and show your ID and go through the police of both sides in order to move to the other side. And there is, of course, free movement for everybody who is a Cypriot citizen, either Greek Cypriot or Turkish citizen, a Turkish Cypriot citizen, not Turkish citizens, and also EU nationals. So this reality is quite interesting, because I will explain a bit about how the checkpoint started to work when it comes to community testing. So Nicosia is in the middle, which is exactly on the green line, as we call it, the line that divides the island in the middle. And this is a closer map of Nicosia, Nicosia center actually. So you can see that half of the actual city is in the north and half of it is in the south. So the realities is something that those of you who have heard about the division of Berlin, for example, we still have it today in Nicosia. And why this is important? Because it's really affecting our work, and this is where we are. The role of the community testing is really important. Now, the movement was established in 1989, the AIDS Solidarity Movement, and the first decades, the main work that was doing was support for people living with HIV, people diagnosed with AIDS, their partners, their friends, their families. That was the main thing that the movement was doing through a single program of having a clinical psychologist who is working in the only one HIV reference clinic, public clinic on the island, which is not even in Nicosia, is in Larnaca, in a different city, 45 minutes drive from Nicosia. So we only have one clinic where everybody, when they are diagnosed, they register into the system, they get a code, and with that code, and the code is consisted of a first name and a number, they go to the clinic and they do their test and they get their medicines from there. So everybody from around Cyprus, from different cities, or people who live in the north and want to have access to the public health of the south. I don't like the Greek side and the Turkish side, as usually people tend to call them. So I use the south and the north, just a geographical way to talk about the two sides. So what is actually happening is that people who want to get monitored and get their treatment, they go to the specific clinic, which is a public hospital in a city outside Nicosia. Now, in 2015, when I joined the movement, we did not have a permanent space. we did not have a place to house our activities. We would meet in cafeterias and have meetings, and we started having we bought a tent, the one you see on the picture, where we were moving around. It was not even a car, it was a tent. So we moved around in different points of the island to provide community testing. We went there like half an hour before. We set up the tent. We did the community testing part with carrying bags and banners and the tests and everything. And then again, put everything back into their cases and storing them in our own houses. So this is how the community testing in Cyprus started in 2015. And it's important to say that the population of Cyprus is around 1 million for both sides. So we're talking about a very small population, but there are about at least before the COVID era, about 5 million tourists passing by the island in the summer period. This year was the first year that we have our own space. We managed 5 years later to have our own space. This is the training room that you see, and this is the small room we use for testing, and our small kitchen. So what we did strategically was, first of all, to make sure that the people at the ministry knew that we have access to these communities, and these are the populations that we are also serving. I'm talking, of course, about the LGBT community, men who have sex with men, sex workers, migrants, people who are involved in chemsex, people who use or inject substances and drugs. So this was the first one, the access to the populations. Because we are a small place, and this can be a good strategy for other places that might have an issue with community testing. What we actually needed was a kind of a reassurance that this operation would not be stopped. So we started going to and participating to summits and trainings outside Cyprus. We started creating a network, participating in other networks, and we managed to have some announcements that for some countries it might be not very important, but for us we really used it, and it was really important for us. For example, the mention in the European Testing Week for the success story of how the Cyprus checkpoint was operating in 2019. Same thing goes for the European AIDS Treatment Group success stories in 2017. And in 2018, we had a picture from our tent, not even a text, just a picture with an explanation under the picture that this was the Cyprus checkpoint of the tent in the compendium of good practices in addressing in the World Health Organization report for the HIV response in the WHO region. So we used that in order to make sure internally, nationally, in the country that people of the ministry knew that we are being praised, let's say, for the work that we are doing in Cyprus. And before I go into the testing challenges, which is the main thing that I think can sparkle the discussion in a minute, what I would like to add is that the strategy also included that we collect data from the testings that we did. You saw the numbers here. We're talking about 3,000 tests in 5 years, with 19 reactive tests, which is pretty low. I have to add another 2 reactive to the testing week. So we are now to 21, but they are pretty low. They're not a lot of a load of numbers there, a load of statistics, but we managed, because we did keep that data through the forms and the pre-test counseling process that we did, to be important enough for the ministry to ask us to provide data, community data, for the Dublin Declaration. And then we started doing some trainings, not only for our volunteers, but we tried to get some funding to do some trainings for people who are professional health workers in the HIV reference clinic and also in prisons or in schools. And we managed to gather something like 25 people that we trained on community testing and the approach of the pre-test and post-test counseling. And that led to this year having the Cyprus National Addictions Authority suggesting that we provide them training. This is a national authority in Cyprus to provide training for them, for the harm reduction centers, and test their nurses basically in the community approach. So overall, the strategy was to try and strengthen the work that we were doing. It actually worked. And and we are only doing, like Daniel said before, it's so important to be providing tests beyond HIV. We were providing HIV and syphilis because these were the tests that we could actually buy. This was what we could do in terms of funding that we had. Although the training that we did, we included Hep B and Hep C, and we are still waiting for the ministry to provide us with kits, with test kits to cover hepatitis B and C. So I'll go back to this map just to say, close my presentation with a few challenges that we had regarding what community services and community testing means in Cyprus. It is important to understand that a lot of times, especially for countries that are low in terms of HIV, low prevalence countries, to understand that the work that we are doing is not only about testing. And as we define testing in the previous sessions, testing is not only about the actual test, is about the process of approaching populations that are hard to reach. It's about reaching them and providing them an environment that is safe, and counseling and information given in a way that these groups can actually receive it. And often enough, these groups cannot receive or don't have the access to receive this kind of support and information regarding their sexual practices or their use of substances, or both. So the idea of providing what we call in a one word testing, but we mean so much more, is a lot of times the way in to talk about other things that we care about as a community and as community organizations. And I'm talking about human rights, about rights of people living with HIV, about stigma. And stigma is not just, stigma is a strange concept because it's not only about living with HIV. It's also about being trans or being gay or being a lesbian, or even stigma about testing itself. We're talking about a small country of 1 million that is divided into two sides, but is operating as one in terms of the population contacting each other and the sexual activities going on the island, and to understand that the testing process is, and the HIV activism is opening doors to train even public services in terms of the non-judgmental and safe, and how to create a safe environment for these groups and these marginalized populations that we care about. And for us, it kind of worked. In 5 years, we managed to have our own space, and now we actually got some funding for doing testing for migrants, because there is a rise in people who are not Cypriot and are basically coming as asylum seekers in Cyprus. So it looks like, at least, yes, we are not operating legally. We are in a gray zone, but it looks like the ministry trusts us enough to reach these populations that the ministry cannot reach. And going back to the challenges, to close my presentation, in the first lockdown that in Cyprus happened from end of March until beginning of May, yes, if you look at the map, it's a very small place. We're talking about an island that if you move from Nicosia, which is the capital, to the seaside city of Larnaca, where the international airport is, it's about a 35 to 40 minute drive. And then if you go to Limassol, it's another 40 minutes. And if you go from Limassol to Paphos, it's another 40 minutes. So we're talking about a really small place where each city is about less than an hour drive. Still, the mentality is that of a bigger country where people don't move very easily from one city to the other. For us, it's a long drive to go from one city to the other, because if you're spending like 5 minutes to go to work or 10 minutes to go to work, yes, 1 hour to move to a different city is a lot. So when we were doing testing before COVID, we actually moved around these cities and carried the tents, and even used spaces like the Starbucks conference room to provide testing in Starbucks or in other cafeterias that they had a single office that we could provide testing, or in bars, for example, and saunas. So the idea was to normalize testing. We don't have in Cyprus, and we'll talk about it in the next session as well, we don't have other forms of testing like self-testing or sampling. Sampling testing. So the community testing that was absent on the island made a huge difference, even for people. Even for people who are not visiting the pop-up test that we provide in different cities, or the actual checkpoint in Nicosia. And it kind of started allowing people to relax a bit psychologically and realize that, okay, it's not a big deal to go and get tested. And one thing that happened in the COVID area was, if you look at the map on the far right, there's Larnaca, where the HIV reference clinic is situated in. So if you were living in another city, in Limassol, Paphos, or in Nicosia, for example, I'm talking about the south side, in order to move to Larnaca to get your medication or to do, okay, I'm not talking about monitoring and doing testing, because during the lockdown, this monitoring was stopped. But even to have access to treatment, you could not do that, because you would need to send a text message for going to hospital. And if you were going to be stopped on the way from a policeman and ask you, why are you going to the hospital in Larnaca and you're not going to the hospital in your own city, you would have to come out with saying that you're positive. So there was a huge problem with that. And what we did was we actually created a team of 3 people who were going to Larnaca, picking up the pills and going and disseminating them, sometimes sending them with courier. Sometimes we disseminate the pills with our own cars. We drove to the other city and gave this treatment to the people who wanted it. And there was something that I think, if it was not for the community, and I'm not talking only about our organization, but the LGBT community and organizations as well, and if it was not for the community services, these people would not have access to treatment. Now, I'm not even touching the fact that if you are a Turkish Cypriot living in the north and getting tested, getting monitored and access to treatment from the south, which one of the reasons that Turkish Cypriots often do that is to avoid the stigma and the gossiping in the north, exactly because the population is even smaller, so the stigma is even bigger. So if you were living in the north in the period of in the lockdown, the first wave, you were not able even to cross from the checkpoint. So we had to really become creative on how to cross antiretroviral treatment to people in the north who were not able to say why they needed these pills and what these pills were, but they needed to have access to it. This was one of the major things that we faced and we had to tackle. And closing the presentation, now with the second wave, another problem that we have is that there are people, I'll give you a practical example. The people who during the European testing week were tested and had a reactive test, they need their partners to get tested. Their partners might be living on a different city or even in the different side. So the challenges and the support needed and the role that we have as a community organization or community organizations in general goes beyond the actual testing itself. It starts from the testing because it looks like the HIV testing is what the authorities or what the ministries care about, really. The numbers, the statistics, the tests. But it's also a door that allows us to go through and provide different kind of services to public services sometimes, or not directly to people, to beneficiaries, to clients, or to members of our community. It's the door that allows us to do that. And what we all are really doing in the community testing approach, let's say, in the community services in general, I don't think anybody else can actually do. So I'm hoping that this presentation can give you a taste of what we face in a small island with a lot of complexities, with a lot of different languages and nationalities. We even try to translate all the posts that we're putting on Facebook and into English and Turkish and Greek, because some people don't speak the other language. Imagine that I am Greek-speaking Cypriot and my Turkish is really poor. I've taken some lessons, but the Turkish that I know is not on a is not on a level to actually communicate in Turkish. And the same thing goes for Turkish-speaking Cypriots. Their Greek is not good or none. So we use English to communicate. And one way that allowed us to operate on the island with organizations from both sides and provide this kind of services to the community, despite of the national backgrounds, let's say, of the side, was exactly that. Translating a post on Facebook allowed people from the north to reach us. We even had, and I'll close with this, the one thing that really touched me was around 2 years ago, we had someone who was from an African country studying in the north side, a student, a youngster student, who had a home test. I don't know actually how he got the home test, because you can actually order it online, but it's even more difficult to get it if you're living in the north. But not a lot of people know that there is access to a home test, and the home test was reactive. And for someone who is not Cypriot, living in the north side, and having a student visa with laws on both sides that suggest that people who are being diagnosed should be deported if they are not Cypriot or European citizens. That would mean that this person would have to either not have access to treatment, so he would not be saying that he got diagnosed. He didn't even have access to a second test, beyond the home test. And he could not cross to the south because he was not Cypriot. So he could not have access to our location or the services in the south. And we crossed in the north. We provided the counseling and the support. We tried to find solutions for that specific case that was really, really difficult. And the solution we had went even through Turkey with fellow activists and friends who live in Turkey, who gave us some consulting of the laws in Turkey. And this person was able to find a solution, find let's call them windows in the law, so that they could actually register in the system in Turkey and have access to treatment, finish their studies, and actually have free access to treatment. And I'm not sure if this person even wants, or I don't think that he wants to go back to his country in the African continent. So I don't think his siblings or friends know about his status. So imagine being someone like that, in your early 20s, coming from an African country, studying in a country that is not yours. It's not your country, and feeling the fear for your health, for what an HIV diagnosis would mean. And what happens if somebody finds out and they deport you and your studies are stopped forcibly, and how do you move on in life? So I'm just giving you some practical. I can't tell all the details, obviously, because we're recording the session. So I can't tell you how we managed to help people in the lockdown to have access to treatment, or how we actually help that specific person to have a registration in Turkey and have them the access to treatment. But when I'm talking about community organizations and people in the community, I'm not talking only about local communities. The network is extremely important. And the actual impact we have on people, even if it doesn't show on statistics or in numbers, it's equally important. So thank you. This was from my side. I don't know if there are any questions.
Okay, so as like last time, we prepared some questions for you. To encourage the discussion, and because we also would like to know about your own countries and your own local situations, about what is happening with community-based testing in your country. I'm going to share my screen with those questions, and then you can just unmute and talk. So the questions we prepared are: what does community mean in your own context? How is community-based testing working in your country? And as I said, it's not only the country, but also in your city maybe, or in your village, if you're in a village. Who are the people more at risk, and do they have access to testing? Why do you think it's important to have community-based services, and are those services integrated? And what kind of advocacy would be needed in your country around community-based testing, which is something we addressed a bit earlier, but it would be good to know for each of your countries. So we would like to talk about that country first.
I can go first if no one else jumps in.
Yes. Thank you, Juan.
You're welcome. Well, so in my country, the community means, working on a community organization means working having in mind the culture of the people and the situation that is around it, the people we're working with, and taking it in context to apply to our job. And the community-based working and testing in my country is going quite good. It's almost done by non-governmental organizations, so it's depending on public and non-public money. But there is like in almost every city, there is some organization. So there is testing in most of the cities, but not in all of them. But anyways, with the Declaration of Paris, a lot of cities have joined. So there are more and more checkpoints opening to work towards the 95-0. And the people who are more at risk, as many countries, are the men that have sex with men, transgender people, but also migrants. And now we are finding that also between men that are having sex with men, there is an increase of people in a big risks of STIs, which are the people who are doing chemsex practices, that we are finding they are growing like in a very big number after the lockdown, and is increasing every day. And we are finding most of the HIV reactive that we've had since the lockdown is because of sex parties. And there has been an increase on reactive as well because of this. So this is a problem that we are now trying to address. And well, having community-based services is important in every country, because I think we can provide a different service that they do in the health system programs. We are more close to the people, we understand them better. They see us as an equal, so they can feel, I don't know, more comfortable with us. And also the way we approach them is not the same that doctors do. Like doctors usually in Spain, they are always saying, oh, you need to use a condom, don't do this, don't do that. While on our perspective, we are saying like, okay, you can have sex the way you want to, but I will give you the information so you can handle your own sexual health by yourself. And I think that it's very important, because when someone goes to the doctor and they ask them for the PrEP, or maybe to get a blood test or whatever, the doctors are always giving them instructions and denying the test or the PrEP services just because they are doctors and they think they have the right to tell people how they need to have sex. So this is a bit confusing. So that's why community-based services are important, in my opinion. And that's all from me.
Okay, someone else maybe?
So you definitely raised a good point there. So here in Iceland, we will have 3 nurses, and we have 1 hospital in the capital area, Reykjavik, and then 1 hospital up north in Akureyri. So here in the capital, we have 3 nurses. So if you can imagine the population, families know families. So even if you don't know of that person, you're going to know of that person. And you just said a really good point about the doctors. So community-based people, like Christoph, you had me crying. I don't know if you noticed, but I was tearing up. That was a beautiful story, what you just shared. So thank you. And that's kind of why I've gone into advocacy. So we're all humans and we just need the best treatment, the best advice, but ideally it's up to us. So I don't want the nurse telling me or other people, you should do this and you shouldn't do that. So that was a really good point. Thank you for sharing that. And Christos, yeah, you've just shared exactly what can be possible in a small country with a small population. And it is not just about testing. So that was a really good point. It's more important, all the other issues that you were mentioning, the human rights, trans, it's all in one. So for us in our country, migrants, when they come here, they will get tested once. It's a regular test that they have to do to have entry into Iceland. And then they don't get to see a doctor, a nurse, any special follow-ups unless they're tested positive. That only happened once. And sadly, that case, individual reasons, they were deported. So there's no testing for migrants. And that's not to say that migrants do not have sexual relationships, because that would be silly. But these are people being excluded from testing. So community-based would be great for us, especially for migrants. And I'll just add homeless people as well. So we don't technically have homeless people, like we don't have people sleeping on the streets, but we do have people that don't own or have houses, so they go into shelters, and they rely on the Red Cross organization to come and give them testing or like self-harm reduction policies through the Red Cross. So again, that's something that we could join up with other non-government organizations here in Iceland. Oh, and if I could just ask one question, if Maka is still here, just in regards to the 3 coupons, that was a really good idea to see the seed and how you went through the communities. Could you, if you are still on, could you explain a bit more about the coupons, maybe a little bit later?
No, okay. You mean the definition of coupon, how it looks like, yes? It's very, very, very ordinary one, like your visit card. There is a space for unique code to write, and on the other side there is the address of your organization and the phone number of a counselor who will receive this person for PDI. Frankly speaking, the PDI is not quite an easy model to talk about in 15 minutes. I'm doing 3 days of training on it. But in case you will need any kind of information, additional information, and you will need forms, working forms or coupon styles or anything, you can get in touch with me separately. Marina will give you my mail and I can send them. There is a wonderful coupon tracking form that underlines which client is brought by which drug user, so clients, how is the linkage between them ensured. So I can support as much as I can. But if you consider to use this model in MSM population, they also, besides of financial incentives, they require additional bonuses, like some free services, drug users need only money and less money than MSM population. So at first you should define what will be interesting offer for them to participate in this kind of study.
Would anyone else like to share their local situation or what they're working on? I know some of you are working in community-based organizations, so maybe you can explain what you do and what kind of populations you're working with.
Sorry.
Hi. Sorry, Jean.
No,
you go ahead.
No, I was going to just ask a question, but out of the topic, so you can go, please.
Okay. Thank you very much. Sorry I'm late, but I did catch Georgia, and I also listened to Cyprus. Very well done, guys. You're doing a very tremendous job, and it just makes me feel, that, we're not alone. We're all like a group, and we need to network and hear from one another. We do run a testing service, and because we are an NGO and we're in the Midwest of Ireland and we're in Limerick, so people that are in the Midwest, they avail to our services for rapid testing. It's the only service that offers rapid testing, and we also do we deal with the LGBT community and migrants. The only thing I think at the moment is that a lot of people, it's either they know, but they don't want to avail to the services because of stigma. There's a lot of stigma surrounding HIV here in Ireland. It's only maybe since last year that people are starting to embrace HIV, but there's still a lot of work that is needed on the ground in order for people to really get into the testing. As for testing, we kind of like get a lot of people from non-nationals, so that includes migrants and maybe people that are coming into the country for work or studies. Those are the ones that frequent the services for testing. We also go to direct provisions. Asylum seekers here in Ireland, they live in hostels. So we take the services to them for testing. So the first thing we do is we go and we educate the management of the direct provision or the hostels. We educate them about HIV, and then we go back and we do another training on HIV to the asylum seekers themselves. And then we put up posters offering testing services. That's when we see, because before that, we used to just put up posters and say we're coming in for testing and nobody would pitch up. But if we go in first to educate the staff and then go back in to educate, when we go back in to educate the asylum seekers, then we see that they come in for the test, because the first people we educate, which is the staff actually takes the message over to the asylum seekers. They are the ones who first educate the asylum seekers. By the time we come in, they already know something about HIV, and when we go in, then they actually they will come and listen to the talk, and then after that they come and do the tests. And another thing is we also see a number of MSMs that do testing, but to be honest, heterosexual people not really, they don't really come unless they really were at risk. Maybe they went on holidays or something, or there's not much of HIV education here in Ireland, and which is something that we're working on, as we started a campaign last year of U equals U, and we see that a lot of people got interested in that. And when you ask people about HIV, they will tell you that they know what it is, but for them to come for testing, that doesn't happen much. But we do get numbers, especially in maybe Dublin and other counties where the numbers are very high. In the recent years, like the past maybe 2 years, we've seen a number of migrants from South America coming in, and they're the ones who really avail to the service. They are the ones who come testing most of the times, and they will go and tell their friends and tell their friends and tell their friends to come for testing. So maybe that's all I can share. Thank you.
Can I jump in just to say a couple of things? So actually, you raised again a very good point on something that it is very variable from context to context, which is how do you actually reach the people that you're most interested in reaching? And issues around stigma and discrimination, the way that HIV is seen by the general community, the way that HIV is seen by specific communities. As you were mentioning the example of your work with asylum seekers, for example, we had similar experiences in some migrant neighborhoods where basic HIV education in the original countries is not very high. And so there's a lot of prejudice and stigma around HIV. And so you can't just go there and start testing. It needs to be, as you were saying, a process. Whereas if, I mean, if we go to an MSM venue, for the most part, if you get the tests there, it's done. People will go. So you really need to be aware and know who are the people that you want to reach so that you can adjust your strategies properly. I mean, Christos was speaking about the issue of language. If people don't understand what you're trying to tell them, well, they won't come for testing. That's guaranteed. And I mean, you have to take into account the culture of the communities that you're working with, religious values. If you're talking to men or to women, because the role of genders, unfortunately, is still quite different in many communities. So there's a lot to think about.
I have a question to Anne, or to everybody basically, but I think Anne was the one who mentioned it about, you know, testing heterosexual populations, for example. One thing that we faced, and I'm wondering if other community settings have faced the same thing, was first of all the LGBT community coming and asking whether we are just testing the community or we are testing everybody. So the argument was, are you just doing this for gay people, you know, for the LGBT community? Is it just us? You know, are you targeting us? Because I haven't seen you anywhere else, you know, although we had been you know, in places like Starbucks, for example. This was one thing that I felt that the organization work, especially in smaller populations or in places where stigma is higher, that doing work in a more generalized population is quite useful to reach the marginalized populations. And the other part was that when you actually do work in more neutral spaces, let's say, one thing that I noticed is that you need to be consistent. Even, you know, you're the first time you go, you might have just none or one or two people coming, and then the second time more people are coming. You know, you go from 2 to 5 and from 5 to 10, and then without realizing it, you've got people who are bringing their friends in. So I would say one other thing is that not only it's useful to test the general population and the heterosexual population, or even be there visibly, but also it grows. You know, you need to give time for the development. So I'm wondering if other people are facing similar challenges.
Can I jump in just to say one thing following that, which is a very important point? So this logic of targeting or not targeting is a very interesting balance, because on the one hand, you are supposed to provide a tailored approach. So you are supposed to understand the culture, the preferences, the language, to know the practices of the communities that you're working with. And on the other hand, in many of these contexts, you have to keep as much neutral ground as possible to make it easier for people to access. So it's two levels of work that are not always easy to maintain. And there are decisions that sometimes are strategic. I remember when we opened Checkpoint in Lisbon, the decision was to make it clearly an LGBT flagged location, because it was a political statement as well. And obviously we were afraid that people, and I mean there are big glasses in the checkpoint, so we were afraid that people are going to break the glasses and etc. But it was actually relatively peaceful, and so it became the place where people who identify as gay men from the Lisbon area and even from other places go to test in that area. But people who don't identify as gay men tend to look for other testing sites because they don't want to be seen there. So there's a part of the of the gay men community that Checkpoint doesn't reach, or reaches much less. And so it's also like implementing the intervention is also, we also have to make these choices oftentimes, and there's usually not a perfect solution.
Just to add on to that, and you're right, because our organization, even the name of the organization is Gender Orientation, Sexual Health and HIV. So at first people used to think that it's only for LGBT people, and then migrants. And you see that if we move the services, because sometimes we move the services, we go to a neutral place. When we move services to a neutral place, we have volunteers in the streets walking around and just giving flyers and talking to people and saying we're doing testing in there. We only do that maybe an Irish AIDS Day, or when there's when we're having festivals, gay festivals and all that. But then still, if you're having gay festivals and you give them the flyer, they kind of like are like, no, no, I won't test. But what I find is that the moment you talk to people about HIV, and the moment you introduce the moment you tell someone that if you're talking to them and you ask them, do you want to tell me you've never had sex in the past, you've never had unprotected sex in the past 10 years, and they look at you and they're like, what do you mean? And you're like, well, that's how long the virus can stay in your body without you even realizing that you have it. Then that shakes them, then that they're like, what? And then you're like, yep. So they will go and sit with it, and then at the end of the day you will see one of the days they're like, you say something to me and that's why I'm here. I'm like, good, sit down, let's do the test. But we're learning, and as I say, step up. I'm learning quite a lot from everyone, and it's good that we have this space to share experiences. I'm loving it, and thanks everyone for sharing.
I would like to say something about what Anne just say. It's the same here. We find the same. But one of the things, because we do different actions to reach every population, even though the LGTB community is our main goal, but we do campaigns, go to the streets. But the thing that I've seen that works for the best here in Spain and for us is to go to university. And again, when you give them the information, you give them the chat, then there is a lot of people coming in to get tests, and then they tell to their friends. And after a few days that you've been in the university, they are coming to our center. But once time has passed, they stopped coming. So you need to go again. And I think that's a very good point. And in universities, we are reaching young population that in the future will be aware of this STIs testing. So that's a very good point, and giving education is the main thing, I think, as well. And yeah.
So has anybody had any kind of fight back, or where the national, so if it was a National Health Service that are providing the testing versus the community, has there been like any competition, or can it work hand in hand? Like, have you got any experience of that?
We have experience here. What I feel like most of the times is like, I feel like the HSE, which is the health governing body here, the hospital, the STI clinic where everyone goes to, because here health system is centralized. So HIV medication is only distributed in specific STI clinics or HIV clinics. So you find that for me, I find it very, very sometimes difficult to reach out to them, in as much as they need to reach out to us, because we're the ones on the ground who are actually doing the rapid testing. Because what I see is that people first come to us to confirm or to get a test so that they confirm that they have they're living with HIV, and then they go to the clinic for further tests. But I find there's kind of like this thing of saying, we are the hospital that is governing this HIV, this whole HIV thing, and you are just, our sisters who are just helping on the other hand, and we've tried kind of like having meetings or coming together to say, we have the services. So for me, the way I think about things is that we provide the psychosocial side of HIV, and they provide the clinical side of it. So if someone is going for the clinical side, they go in for treatment and everything, and at the end of the day, they will need the psychosocial part of the whole thing, but they don't have counselors or anybody or support work in the clinics. At the end of the day, when someone goes in for their medication, they are given their medication and they're sent home. And it's up to the client now to start Googling, because all the people who are looking for support, when I ask them, where did you hear about us? Who told you about us? They'll be like, oh, I Googled. And you're like, did the clinic not say anything? And they're like, no. The only time that I can be able to support someone is when they come and I do a test and the test is reactive. I actually make sure that I book an appointment for them at the clinic. They go to the clinic and I follow up, like for the whole week. I'll be calling and just wanting to know where they are, how they are, and how everything is going. And after that, then I bring them into a group. We have a group which is slowly growing, but we bring them into the group whereby every now and then we meet. We might go away for weekends away or go for drinks or something like that. But that's the way I've started building this group. But without that, the hospital is not cooperative. The hospital is like, we are the hospital and thank you very much, you're sending us people and goodbye, which is very frustrating. And I get very, very frustrated with that. And in as much as I'm also a patient, right? And I meet the consultant and I talk to her about things. I talk to her about, the support and all. She kind of like just, the way I look at it is like, you're also a patient, so what? That's the way I feel. And it's so frustrating.
Just something to add on what Annie is saying. What we realized when we have a reactive test, we actually accompany the person. We suggest that we can go with them, and we didn't have not one person refusing. So by being with them, in the process, it doesn't only serve the support of the individual per se on just that, but it also gives a message to health professionals in the national system that these people are coming from the checkpoint, or the CBVCT center, or from the community, and someone is accompanying them. So often enough, they feel that someone is watching and they need to do a better work than what they are usually doing. And what we found was that along in the process, not too far from the first a few times, the health professionals working in hospitals kind of felt relieved, because they didn't, it was like we were doing their job in terms of announcing a result or supporting that person. And they felt that, a burden is being taken away. And that way, by realizing that you are really doing part of what they should be doing, because it's not my job to announce a reactive result, especially when it's coming from the hospital, or when it's a second test, and they are. But I think that they become allies. And then what we managed practically was, in the beginning, we had to take someone and they had to give blood for the first test, wait for a week, get the result, take another test, for a second test in the public health, wait for another week. And sometimes the 2 weeks period would become 3 weeks period, and then linked to care. And now, at least I can say that this is happening for at least two years now. The people that we take, and they already have a reactive result from a rapid test that the hospital doesn't recognize, they are skipping. They are still doing 2 tests, but they are doing it on the same day. They're taking different samples and they're testing them, and then we minimize the time, and you can see that these people start to trust you. So find ways to make people in the health service realize that they can be allies, and they have something to gain out of allowing you to do this.
I think that to add on to that, I think that the situation is relatively similar with most of the people that I've spoken with that do community testing, and is also similar here in Portugal. When we started, there was a lot of resistance from the National Health Service, and some of the resistance is justified if you think from the other side. We're speaking about people who at the time had no idea about community-based testing. They had no idea what it was. They didn't know what tests were being used. They didn't know these people who suddenly want to do tests and tell people that they're HIV positive outside of a hospital. These people are nuts. Obviously, we found a few people who were more favorable, who were familiar with WHO and ECDC recommendations. This was 2011, I believe. So it was very recent recommendations. And we managed to set up a pilot. So we started small. And as Christos was saying, things grow with time. These things don't happen overnight. And again, with referral to care, which is absolutely essential. We also we go with people if they want us. Of course, we offer to everyone. And as Christos was saying, it makes a huge difference because first of all, you get to know the people in the hospital. I mean, the people in your organization who do this work will be priceless because they will know the security, the administrative people, the nurse that's head of the shift, the person that's in the lobby of the HIV clinic, and so they'll know the system. They'll know the actual hands of the system, and so they will be the best placed people to know how the system can be made better for the people. And I think that the angle is exactly what Christos was saying. And you will find resistance whatever you try to change. People don't like to change. People tend to like to leave things as they are in general. Especially if it's people who, in case of doctors in pretty much everywhere in the world, they're sitting in with a truckload of cases to manage. Or if they're politicians, they have 1 billion people knocking at their door with 1 billion requests. And so we have to have a process to kind of create priority for this. Otherwise, it's one thing in the middle of many. And this relationship with the hospital, providing solutions to things that are difficult for them. I'll give you a practical example from our context. We have a lot of people from other countries, particularly from Portuguese-speaking countries in Africa and from Brazil, which is also a Portuguese-speaking country, as you know. And many of these people are in Portugal without papers. And although in Portugal, people can access health care without papers. It's allowed by law, which is fantastic. You need some administrative procedures for this, and people have absolutely no idea how to process these administrative procedures. Plus, you get bills from the hospital. It's an automated process, so you don't have to pay them, but people don't know that. And suddenly they're getting bills of 150, 300 euros, 500 euros. So if you don't have support, even for a national citizen, this has nothing to do with where the person was born. Even if you don't have support, it's very difficult for the person. And this type of things you can sort out with the hospital. If in the hospital you know that a patient one of the people that you're going with has problems in a certain angle, as Anne was saying, you provide other forms of support. But it takes time to build these relationships, and it takes time to build trust. So it will always be a long process. But we persevere in the end. I haven't seen one single country in Europe where community-based testing started and it has stopped since. It always perseveres. It's hard, it takes time, but usually it stays there.
Just one more thing from me, because I have both situations here, professionals that works hand to hand with me or with us, and professionals that they don't want to work with us. Here in Malaga, we have a couple different hospitals. We work mainly with 2 of them. So when someone has a test reactive for HIV or hepatitis in our clinic or center, if they belong to one hospital, I just need to send an email to the doctor, and the next day that person will have an appointment. It's the same for PrEP. we make a really good relationship with that professional. While on the other hand, we have another doctor. It is the chef of the HIV clinic in the hospital, and we have tried to make the same with him, but he refuses. So every time a person got a test, they need to ask for an appointment with primary care. So they need to have a test there. Then when they have the results, they need to go to the doctor, have another test there. And this can last for more than 1 month to start taking your treatment. So in my opinion, it's depending on the professional and how committed he is with his work, maybe. So 2 different examples in the same city. It's quite annoying, but it is what it is.
Yeah, people will always be people. Sometimes some people are just impossible.
Thank you, Daniel. I think you managed to do another great conclusion for this session. I think we can keep that as the
Yeah, some people
main
are
conclusion.
impossible is a good conclusion for anything in general.
I will keep this quote. We can reuse it. Okay. Okay, so maybe we can close it here. Thank you everyone for joining and participating. It was really interesting and inspiring as usual. So we see each other on Friday during lunch, and we're going to talk about self-testing. So I wish you all a very nice evening, and see you on Friday.
Likewise. Bye-bye, people. Have a nice evening.
Very much.
Bye,
That
guys.
was very
See you
good.
Bye-bye.
Friday.
Bye
That was
bye.
good. Thank you.